So I'm delighted to be back in Krakow. The Institute, it's been, I think, 6 years since I've been here. And I'm here to talk about the development of glutamate-based antidepressants, how we got to where we are now, and maybe where we're going to go. And I'd like to thank Barbara Kruchik-Smaga for that introduction, so it saved me a lot of time. It's still going to be a long lecture, but I think she provided a lot of the background. So let me get started, and hopefully we'll have time at the end for questions if you want. I have to show a conflict of interest statement. Currently a fellow at Indivior, but there's no financial conflicts. This is a drug addiction company, and I'm only talking about depression today. And of course, the opinions and conclusions are my own and don't reflect those of my employer. Basically, they were happy to get rid of me for a few days so I couldn't bother anybody. So this is from a Time magazine, which used to be a very famous American publication. It's about 12 years ago. And the most important area is ketamine for depression, the most important events of the 50 years. You know, the journalists have to be journalists, but on the other hand, this is really a change in the biogenetic-amine-based paradigm that we knew about for so many years, as Barbara pointed out earlier today. So how did we get there? The first hypothesis-based theory that NMDA antagonists might be antidepressants was in my lab by Ramon Trias, who was a student at that time in the laboratory. And like many other papers, this paper we sent it to Science because we thought it was pretty important. And they rejected it as another pharmacology paper. And so I think what's important is we say here that the substance capable of reducing transmission to the NMDA receptor may represent a new class of antidepressants. And so that's the essence of the work. And my team, including people from the Institute of Pharmacology, published a number of papers on the behavioral and neurochemical aspects of NMDA antagonists as antidepressants. But it took about 10 years before the first paper came out, Trias and Skolnick, and the paper of Rob Berman, who actually serves on the board of directors with me for a different company, showing that that ketamine had antidepressant effects, intravenous infusion, in treatment-resistant depression. So this is a very, very important paper, but it took 10 years between the first publication of Trias and Skolnick and this paper to appear in Biological Psychiatry. So let me just refresh. I'm sure you've seen things like this. I think Barbara showed something like this. This is a change in the HAM-D score. And this time scale, for those of you in the back that I know can't see this, is minutes, not days and not weeks. So it's already different than biogenic-amine-based antidepressants. So 3 hours after the stop of that infusion, it's a 0.5 milligram per kilogram for 40 minutes. It's a slow drip. Everybody uses that, and it used it. There are now dozens of reports in the literature. You get a diminution in the reduction in the HAM-D score, which is highly clinically meaningful. And it was retained here for three days. And in fact, they say in the paper, it was there at 7 days. The other thing that I want to mention to you that's very, very important is that there is a spike in the visual analog scale, a high score, and also in the brief psychiatric rating scale of positive symptoms. So what this means is it had some sort of dissociative effect. And we know ketamine has been used for so many years. It's a great anesthetic and a great analgesic. And it causes dissociation because it's an NMDA receptor channel blocker. Okay? So that's basically what Barbara covered. So the question that you have to ask yourself is, we had all this wonderful science, okay, and yet it took a decade before the first clinical study was done. And those papers came from NIH, so it means something in the United States. So this is an article that, my colleagues and I wrote about a year before S-ketamine was approved. And this was not the title that I wanted, but it's a title that the editors allowed us to put. The question is, what I wanted to say was development of glutamate-based antidepressants, why has it taken so long? So that's part of what I'm going to talk about today, because I think a lot of you in the audience were not even born yet when the field started. So 1990, so Prozac was approved in 1988, and it was a blockbuster. Very great. Over the decade of the 90s, every drug company, or almost every drug company, had an SSRI in development. So when we would present at meetings or I came around and gave lectures, everybody said, very interesting, very interesting. But these compounds were making billions of dollars a year for these companies. Now, why would they go ahead and put in a competing molecule, regardless of the properties? So part of the reason why it took so long to even get these studies done was because everybody was interested in SSRIs as antidepressants, how they worked, et cetera, et cetera. The other reason, and this probably as or more important, was in the 80s and 90s, NMDA antagonists solely focused on neurologic diseases, like stroke, traumatic brain injury, things like that. And they were eventually dropped, but this is what every drug company had a program in some sort of neurodegenerative disorder using NMDA antagonists. And so when we went there and talked about antidepressant, they were all developing neurologic drugs, and SSRIs were already on the market. So it was very difficult for pharma, especially big pharma, to conceptualize this change, which would be a sea change in the treatment of depression. They weren't having it. Okay. So I have to show you, this is sort of a funny slide. These are some of colleagues from Merck. In 2002, this is 2 years after the Berman paper appeared, this paper appeared in Nature Neuroscience, and they were still beating the drum, potential treatments for some major disorders such as stroke and Alzheimer's disease. No mention of depression. Okay. That was 2 years after the Berman paper appeared. So the questions go back to the Teresa Skolnick slide, which is more of a reminder for me, is how did we get to this conclusion? Very early work, which I'll go over very briefly because I have a lot to talk about. And if you haven't seen it, if you haven't read the paper, it's probably worth a read. But this is a cartoon, you saw one before, about NMDA receptors. They're ligand-gated ion channels, which I love generally as a class. And when we started those studies in 1989, and it was actually based on a science paper by Tracy Shores, and Ramon figured out that these compounds could be antidepressants. So we took the most specific compounds we had at the time. So the toolbox in the late 80s was rather limited, and so we took what we had. So we had a glycine partial agonist that we were using in the lab called ACPC. We had AP7, which is still used today. It's a competitive NMDA antagonist. And we used MK801, which is probably the most selective and highest affinity channel blocker there is. And we didn't consider a compound like memantine, or like ketamine, because they weren't specific enough. And as pharmacologists, we wanted to make sure if we were testing a hypothesis that we had the most, somebody wouldn't say it's doing it through norepinephrine release or something like that. So we used the highest affinity tools. And the tests we used were the classic tests, the tail suspension test and the forced swim test. This is some of the data using ACPC, which is a glycine partial agonist. It was actually one in phase 3 and with positive phase 2 trials, which acted very much like this. Anyway, you get a dose-dependent diminution in the duration of immobility, and the tail suspension test, the classic effect, with no change in motor activity. Here's another table from the paper using AP7, dose-dependent reduction. It's a charged molecule. It doesn't get in the brain very well, so you have to use very high doses. But at 100 and 200 milligrams per kilogram, you see a diminution in immobility in the forced swim test. So we had data in both the forced swim test, tail suspension test, with all these compounds, AP7 and K1. There was one dose that we used that had an antidepressant effect with no change in motor activity. When you go a little bit higher, you get a huge increase in motor activity, and it becomes like a false positive in the test. So with that, I think we were off to the races. So we had done a lot, did some other work, but I wanted to point out that one of the early papers confirming that work came from the Institute of Pharmacology. From the Mai Institute of Pharmacology, the first author was Professor Mai. So they were early supporters and advocates of it. The other point, this is from Professor Papp's laboratory. Remember this one, Marius?
Of course I do.
Okay, he remembers. So this is a competitive...
Not that bad.
A competitive NMDA antagonist like AP7, because drug companies were developing these compounds for stroke, for traumatic brain injury, not so much for depression, but Marius and Elizabeth Morrill showed that you got an increase in sucrose consumption, you reverse the anhedonia you see from chronic mild stress, very much like you do with imipramine. So you had, excuse me, multiple lines of evidence from multiple laboratories showing this. And over the years, we're talking about 35 years later, if you can't get an antidepressant effect with an NMDA antagonist, you better go back and check your tests, your behavioral tests, because it's very hard to get a negative result. So I'm going to summarize a lot of work from a lot of my former fellows, just to say that the behavioral stuff is very interesting. But there's an aspect of the work that I am particularly fond of that I'm not going to show a lot of slides of, but that you can see with chronic antidepressant treatment. And what we did, we used like 15 antidepressants. We treated animals for 2 weeks, and then we harvested the tissue. We did some neurochemical assays. And every antidepressant that we used changed the ligand-binding properties of the NMDA receptor. And the ultimate result was consistent with a diminution of function, that is a dampening of function, after biogenic amine-based antidepressants. And it took 2 weeks. It was slow to develop, it was slow to come off. So it's very interesting. So if you think about it, we weren't bold enough to say it at that time, but if in fact this had something to do with the antidepressant effect, this dampening of NMDA receptor function had something to do with depression, if you used an NMDA receptor directly, you might get a more rapid onset. Now, the animal tests still don't show that. We were happy enough to show that we could get these animal tests, but that would be one possible reason. But what I will show you, so the neurochemical test, the neurochemical data was really interesting. I ask you to read the papers, but you had to infer that there was a ligand binding assay. You had to infer there was a diminution in function. We also did in my lab, when the technology was available, we did some in situ hybridization. And what we did was we treated mice for 2 weeks with either citalopram or imipramine. And this is very old nomenclature. In the old ancient days, in the 90s, in mice they call the NR2 subunit epsilon. So this is NR2A, NR2B, and NR2C. And what you can see is that the transcription of these subunits in various areas, this is frontal, parietal, occipital cortex, for those in the back that can't see it, are always diminished or not changed. But it's a unidirectional change. And this was 1 dose of imipramine and citalopram and 1 time period. But it's an interesting phenomenon. So not only did you get this neurochemical evidence, but now you had actually some physical evidence that the transcription of these subunits was affected by chronic antidepressant treatment. Okay, let's fast forward 14 years to Joe Ledoux's laboratory. This was published in 2012, where they treated animals, mice, with citalopram for 22 days, completely different endpoint, completely different brain region. And they used Western blotting. And what they found is that the NR2B subunit, that is the epsilon 2 that you saw, now called NR2B, was diminished by about, so you have physical evidence that the NR2B subunits are diminished after 3 weeks of citalopram. So in fact, to me, that actually gives additional evidence that you're getting some change, some chronic treatment with biogenetic-based antidepressants can actually has a knock-on effect through the NMDA receptor. And I'll talk about that towards the end of the topic. But this basically, all this evidence was published prior to the Berman paper. And if you look through the Berman paper, for those who are pharmacology historians, probably half the citations are from the NIH. This is actually from Carlos Zarati's paper, which Barbara showed before. It took about 6 years before that Berman paper was actually replicated, and probably could only be done at the NIH because you couldn't get a grant to do that. That was very difficult in those days. People weren't interested in NMDA receptors for anything other than neurologic disorders. So at the NIH, you didn't have to have a grant, and the study was actually much larger than the Berman study, which is only about seven patients. This was about 20 patients. He used the same infusion, that is 0.5 milligram per kilogram, which is a guy my size, around 40 milligrams, over 40 minutes. Again, the time scale here is minutes, not days, not hours. And you see this change in the HAM-D score, and these are treatment-resistant patients. They failed on 2 courses or more of a biogenic amine-based antidepressant. So you see the effect manifested in about 2 hours. It's there, and it's maintained for up to 3 days and 7 days in some patients. Now, on the right side, just because this is a pontifical seminar, I'm showing what happens with sertraline and citalopram from a completely different phase 2 study. And you can see here the time scale is in weeks, and these are not treatment-resistant patients. And so it takes weeks to manifest an effect with biogenic amine-based antidepressants. And here, after an IV infusion of ketamine, you get a very large diminution in treatment-resistant depression, which takes hours. So it really was a sea change in responsiveness. I mean, that's the only way to put it. Okay. So I'm going to fast forward now because I have other fish to fry, because I think you all would acknowledge that ketamine has some effect in depression. These are from the phase, so all the studies that are in literature, most of them up to that time were from academic laboratories. And so the ends were quite small. The patients are curated. This was a industrial study, was run by Johnson & Johnson, who didn't use ketamine. They used S-ketamine, the more active enantiomer of ketamine, has a higher affinity for NMDA receptors, in treatment-resistant depression. And it was a phase 2 study. And what they did was, the first time that I'd ever seen it, some sort of dose ranging study, because you have to do that in a drug company. So instead of that constant 0.5 milligram per kilogram for 40 minutes, what they did was, first it was intranasal. And I'll talk about the rationale for doing intranasal. And it was dose response, 28, 56, and 84 milligrams. And you see there is what appears to be dose dependence. And the dose dependence is more evident in terms of the duration of the effect. So you still get a full effect at 84 milligrams after a week. And with the lowest dose, 28 milligrams, you don't see too much of an effect. And period 2 is very interesting. I wanted to bring this out to you. What they did was they took the placebo group here, and then they re-randomized them. And you get, in this placebo group, which had a slight response, you get an additional response with the S-ketamine. And again, the duration of effect is largest with its largest dose. So this was actually a very nice study. It was published in JAMA Psychiatry. And so the question is, if I'm on my slide, let me explain the rationale for picking these doses. They weren't picked out of clean air. So if you think about it, I said it now, this is the 8th time, 0.5 milligrams per kilogram for 40 minutes. So what they did was they did some studies with S-ketamine. So they guesstimated, based on the relative affinity for the NMDA receptor, that they would need 0.2 milligrams per kilogram to get the same effect, and indeed they did. So pharmacology works sometimes. And then what they did was they did a pharmacokinetic study, and they wanted to match that with with the 56 and 84 gave you S-ketamine levels that are in the pharmacokinetic range achieved by the intravenous administration of 0.2. So it's rationally based, and in fact, this is one time when everything worked out, the stars aligned. So the clinical pharmacology matched the pharmacokinetics. Okay. So let me stop here for a moment and talk about S-ketamine. So it was finally approved for treatment-resistant depression in 2019. 30 years between bench to approval. So, but the real issue is, and I think probably many of you know that, at least in the United States, that ketamine, IV ketamine started to be used about 2008, off-label. That is, they set up ketamine clinics. There were thousands of ketamine clinics in the US who would offer an IV infusion, 0.5 milligram per kilogram for 40 minutes, and most of the patients got up and walked away very, very happy. But off-label use of a drug is not generally reimbursed in the United States by insurance, and ketamine was not approved for depression at that time. So people had to pay a lot of money for this. And IV infusion is resource intense, as you can imagine. Yeah, it's much easier to give it intranasally. But the real reason why no drug company developed ketamine, IV ketamine, was it was generic. There was no incentive to commercialize it, right? So what the clever guys at J&J did, Johnson & Johnson did, was they took the more potent enantiomer, and they gave it intranasally. So they developed S-ketamine with in mind a patent strategy which enabled commercialization. In fact, I know for, I think 2 years now, it's been what we call a blockbuster in pharma. Anybody know how much a blockbuster sells? North of $1 billion US dollars. That's what the sales of S-ketamine are. And although it's less resource intense than an IV infusion, it still has to be administered in the clinic because you still get a dissociative effect. And so you can't just take it home and use it. It has to be done in a doctor's office or a clinic, as you could do it in a psychiatrist's office, whereas the IV infusion, I don't know, in the US, there are no psychiatrist's office that will give you an IV infusion. So it's actually, even though it's better than an IV infusion, it still limits the scalability, meaning that you can't use it for everybody, because not everybody can go to a psychiatrist or a clinic once a week for infusions. Expensive, and it's still fairly labor intensive. You have to watch them for 2 hours before you release them. So that's one of the reasons why. So other drug companies, and remember I said at the beginning of the lecture that I'm doing okay. I told you that almost every drug company had an NMDA antagonist for development as for traumatic brain injury. Stroke was really the major driver for this. And so once the drug companies realized that these compounds could be transformative antidepressants, they went and repurposed these molecules, which have been failed for, not because they don't work, but clinical trials fail for reasons other than efficacy. And I will tell you that a stroke trial is that's another lecture. Invite me back in 10 years, I'll give you a lecture on stroke trials. So here's a compound called linisamine. It's AstraZeneca 6765. This is a paper by Carlos Zarate at the NIH. It was published about 12 years ago. And they see this is an IV infusion of linisamine. And here's the same time scale as ketamine. And they see a very modest change. I mean, it's not insignificant. It's statistically significant, but there's no duration. It's not durable, not a durable effect. A very sort of transient effect and very small compared to ketamine. Now, the only thing I will just caution you right now is look at the bottom scale. Remember we talked about the brief psychiatric rating scale, and you get this peak, these dissociative effects with ketamine. Guess what? It wasn't here. And so the companies were trying to increase the acceptability, the tolerability of the compound. So they try to give a low dose which got a little effect, but possibly no target engagement. And that's why this effect, or very minimal target engagement, I think that's why this compound failed. Here's another study, a much larger study. Now that was from NIH. That was a small study. This was an industrial study, meaning an industry-sponsored study with about phase 2 with about 50 subjects, 50 patients in an arm. And they were giving this linacimine 3 times a week for 3 weeks. And you actually see a nice effect here, which durability is not terrific, but it's around at the 150 milligram dose. So, but imagine giving 3 weeks of 3 time a week infusions. It's not a practical. It's not a practical thing. And so, as I said, I said it already. Now they gave 3 infusions a week. You imagine somebody coming in for 3 infusions a week, maybe for a stage 3, stage 4 cancer. But when you had the ability to give ketamine once a week, why would you do this? And eventually, they dropped this project because wasn't not that it didn't work, but it wasn't commercially viable. So here's something which is kind of interesting, and it brings me to another point about NMDA antagonists. So this is the conclusion. I'm showing you the conclusion of the paper. Is that ketamine and memantine, when you look at them electrophysiologically, are essentially very similar or identical. What I'm saying, if you blind them, you couldn't tell them apart. And the same thing is with linacimine. Linacimine is very close to ketamine. There were papers published, and if you look in electrophysiological evidence, the duration of channel blockade is quite similar. I'm just saying. So so the question is, why wouldn't memantine be useful as an antidepressant? This is an old paper it's not a paper, it's something that I did with one of my I know I have an email from Marius from about 30 years ago, or 25 years ago, saying that he couldn't get it the animals went to sleep or something in his paradigm. So I do remember that, Marius. But there was a paper published in 2012 using a chronic mild stress paradigm. And they showed that 20 milligrams per kilogram of memantine, which is about the range that I showed you before, given 7 days after 40 days of chronic mild stress, actually caused the animals to consume more sucrose pellets. So it may work. It works in the forced swim test, works in tail suspension test. It may work in CMS. What about clinically? So clinically, this is, again, a very small study, very hard to see an effect with 16 patients in a group. This is from Carlos Zarate, and he didn't see an effect. Now, if I would invite you to read this paper. They titrated up the dose of memantine orally for a couple of weeks. Here's another paper, which I haven't seen reproduced, where they looked at memantine in combination with an SSRI, sertraline. And now again, they don't have placebo, but if you look at memantine and sertraline versus placebo versus sertraline, you do see a slight effect, a slight maybe acceleration or a slight difference in the reduction in the HAM-D score. So this is actually what the data looks like. Again, there's no control, meaning saline, but it does separate from sertraline and placebo by a little bit. So I think, and what the conclusion that I would reach here is that the dose of memantine, they started off with 20 and they kept it at 20. And so I'm going to actually come to so my conclusion is they weren't dosing high enough to get true NMDA receptor blockade with memantine. But the question is, and this has been raised in literature for years, and is there a molecular signal that differentiates ketamine from other NMDA antagonists? And that's been an area that's been debated in the literature for years. So you could have a divergence of signaling pathways following NMDA receptor blockade, or in addition to NMDA receptor blockade, right? It's possible, especially with something like ketamine, which is not as highly selective as something like MK1. So it's possible. But it could be related to the duration of NMDA receptor blockade. And I'll show you some data. I mean, ketamine is very fast acting, it's on and off, but that antidepressant effect persists, so something else is going on. So, activation of intracellular pathways related to the strength and duration of NMDA receptor blockade may result in a very sharp inverted U-shaped curve. Why do I say that? Remember, pharmacology, sharp inverted? Everybody uses a 0.5 milligram per kilogram, but just think about this for a moment. Ketamine has been used as an analgesic and anesthetic for 60 years, right? It's been used on millions of people. In some countries in Africa where they don't use opioids, that's ketamine is it for general surgery. You want to do a colon resection, you use ketamine. And so nobody, and this is to quote my colleague Jeff Witkin, nobody ever got up from ketamine anesthesia and said, let's go bowling. The veil was not lifted. So you have somebody who's gotten ketamine, it's transformational. A day later, they feel great. I mean, some people are profoundly depressed. When you lose 10 or 15 points on a HAM-D score, that's clinically significant. And what I'm saying to you is that millions of people over the years have been treated with high doses of ketamine. What the 0.5 milligrams per kilogram is a sub-anesthetic dose. You get a transient dissociation, but it's probably not even an analgesic dose. It's a sub-anesthetic dose. So what happens at very high doses? Okay? And so what I'm telling you is from clinical experience, there's not a profound or enduring antidepressant effect. So you have this very sharp inverted result. Why? Okay? I don't know. But it's an interesting, so this is one of the hypotheses. This is done in animals with radioligand in vivo receptor occupancy studies. So what they call a hit and run profile may result in a unique pattern of intracellular activation. It's a very interesting hypothesis. You give a dose of ketamine, all these are at the same dose level, same dose level. So you get about 60% of receptor occupancy here. Here's memantine, 60%, and here's MK1. The bottom line is where they use NR2B receptors. These are just a channel block. Okay, this is looking at autoradiography, or actually they use a different technique, but you get this very rapid on and off with ketamine. It's gone by an hour. The antidepressant effects persist. On the right, I'm showing you so these are all channel blockers, correct? Ketamine, MK, and memantine, all channel blockers. These are all selective NR2B antagonists. They all have this very prolonged receptor occupancy of NMDA receptors. So I want you to keep your mind's eye on this one, CP101606. Another name for that is trexoperdil. And so I will tell you that this data by itself would tell you that there's nothing really unique about ketamine. Now, I can't say why anesthetic doses no longer act, but what I'm telling you is that it's possible to develop other antidepressants that work at other loci on the NMD receptor that are safe and effective, or as safe and effective as ketamine, may be safer and more effective. How do I know that? So first I want to go back to some work that we did at NIH many years ago. First demonstration that NR2B antagonists had antidepressant-like effects. So until that time, competitive antagonists worked, glycine antagonists worked, glycine partial agonists. This was the first demonstration that a 2B antagonist worked. And so trexoperdil is a molecule that was developed by Pfizer for traumatic brain injury. And it failed in traumatic brain injury, not because it may not work, but because of doing a trial in traumatic brain injury is horrible. And what I'm saying is it's very difficult to do a controlled trial in traumatic brain injury. So they gave up, but what they said was, well, we can repurpose this for depression. And so this is an interesting design. It's a 2-period study where they started giving people paroxetine and SSRI chronically. Then they gave a paroxetine infusion, so they got the feeling of an infusion, and then another 3 weeks of paroxetine. And these people were treatment resistant. Okay. Now, if you failed to improve on this paroxetine regimen here, you were re-randomized. If you were successful, that is, if you had more than 20% change in the HAM-D, you were out of the trial. You know, paroxetine worked for you, God bless. Here, they were re-randomized to get either paroxetine and an infusion of trexoperdil or placebo and trexoperdil. And these are the data. Now, before I start on the data, let me say that the first cohort of 6 or 8 patients that they did with trexoperdil, they all had dissociative effects, profound dissociative effects. And so they stopped the trial and they reduced the dose by half. So the data I'm going to show you are with a lower dose of trexoperdil. This paper is in literature, Sheldon Prescorn's paper. It's a great paper, and I would advise you to read it. So here we are looking at the MADRS, which is another depression rating scale. And at day 5, they see an 8-point change in treatment-resistant depression from placebo. Okay? They see at 6 points at day 8, by day 12 it's gone. So the question is, why didn't they see the very rapid effect that you see with ketamine? Okay? And the answer is because this was a pharma trial. And so I will read this for you in the back because I think it's important. And I've spoken to Sheldon Prescorn at meetings, and I know this is correct. The statistical plan for the study pre-specified assessing antidepressant response on day 5 after the double-blind infusion, because the HAM-D and MADRS is originally designed to assess change over days rather than hours. That's why they did it. That's why you see the effect of 5 days. They didn't really look hard at 2 days. However, nevertheless, the improvement in the mental status exam, including mood, was frequently apparent on day 2 after infusion in those patients who met response and remission criteria on day 5. So you're getting a response at day 2, which they didn't really quantify, but at day 5 you have a pretty good effect. So I would conclude from that you probably can produce a clinically effective antidepressant effect through multiple loci on the NMDA receptor. Nothing is special about ketamine at this moment that we've seen that's compelling. So here's some of the evidence that tells you that nothing is compelling, nothing is different. Okay. So people have developed NR2A preferring NMDA receptor antagonists. Now they haven't been in the clinic, but in all the animal models, they have antidepressant-like effects. That's in the literature, and I'm pretty certain that this is replicable. Something else. NR2B containing NMDA receptors regulate depression-like behavior and are critical for the rapid antidepressant effect. What they did here was they did conditional knock-ins, and they silence the NR2B receptor here, and they lose the effect of ketamine. So this group argues that you need the NR2B receptor for the antidepressant effects of ketamine. It's very interesting. Here's another paper showing that when you knock out the AMPA receptor, you still get this effect of NR2B antagonists. So you don't need AMPA receptors, which indicates you don't need this. Some people talk about a glutamate surge that ketamine produces. It does produce it, but it's probably not needed for this antidepressant-like effect. There's other evidence that's contrary to it, but I like this was done in conditional knockouts. So you can knock out the AMPA receptor. You don't use drugs, it's much cleaner. And so the question is, I can see I'm running out of time, I'm going to tell you. The question is the failure of other NMDA antagonists in depression due to inadequate target engagement? And this is an article that actually I co-authored. So I think that may be, that you may need a dissociative effect, not because you need the dissociative effect per se, but rather it's a measure of target engagement. And I think that is the real, in my opinion, is the real answer. There's some evidence for that. I'm going to skip over this quickly, just say that when you give something like this is intranasal ketamine, this is a phase 3 study, you get all these effects that you could say are dissociative-like compared to placebo. There's other evidence from the NIH where they looked at this very rapid effect of infusion of ketamine, and they tracked the dissociative effect using multiple scale scores, and they find a fairly good correlation between the change in the HAM-D at day 7, that is that enduring effect, and the change in the depression scale score. That is, the more effective the drug is, the lower more change you get in the HAM-D score, the more dissociation you see. So there you have it. And there's an independent report indicating that there was a correlation with I think they used a brief psychiatric rating scale. So there are 2 reports from phase 2 studies saying that, maybe it boils down to target engagement. However, in the interest of full disclosure, in phase 3, when Johnson & Johnson did this study with esketamine, they were not able to find a correlation like they did with the ketamine infusion. Now, what I will tell you is that the CADS, the clinician-associated clinician assessment of dissociative scale score, may not be the best measure of dissociation. It's a subjective marker. So I would say that the jury is still out, but at this moment, I think that based on what we saw with Traxoprida, where they had a profound dissociative effect with the 2B antagonist, and that you need that in order to see clinically effective. And that also explains the failure of things like memantine and linicamine. So I'll just point out to you that scalability is the only way that you're going to see additional NMDA antagonists on the market, where you don't have to use these labor-intense and time-intensive methods. And so just to think back in time, tricyclic antidepressants have been around a long time. They're not any better. In fact, they're probably not as effective. SSRIs are not as effective as tricyclic antidepressants, in my opinion. But they were prescribed mostly by psychiatrists because if you take a bottle of imipramine, you can kill yourself. And that actually happens sometimes. SSRIs are safe. They could be used by GPs with very little training, internists. And so that's why they took over. So what you're talking about is scalability. And so there are multiple companies that are using oral NMDA antagonists for depression. And the problem, they want to take it out of the psychiatrist's office and take it home. And to do that, you may get the trade-offs, maybe based on what I told you before, a loss in the speed of onset and perhaps even lower efficacy. But will we ever have that something that you could take home, not produce dissociative effects and have the same profound effects of ketamine? That remains an open question. I think I'm going to leave it like that. Now, in the last, if I might, another 5 minutes, you'll indulge me? Okay. I know. And I'll stay after and answer as many questions as you want. Because I want to talk about an old cartoon that we made. It was something that Barbara focused on for a moment. It was this BDNF. So remember I told you that conventional antidepressants, the work that was done in the laboratory many years ago, could downregulate or dampen NMDA receptor function. There's some evidence linking the formation of BDNF to that. And we realized very early on, actually, when I was at Lilly, that AMPA receptors are probably the most powerful, that's Hans Turnen's old work, the most powerful stimulant of BDNF in the central nervous system is AMPA receptor activation. Now, AMPA receptor activation is not something you can make a drug out of. Why is that? Because it's an excitatory neurotransmitter. You will depolarize the membrane. You'll get rid of the magnesium block. You'll open up NMDA receptors. That's not a good thing. And you allow calcium into the cell. And if we know that NMDA receptors produce a antidepressant effect, you don't want to activate NMDA receptors in depressed patients. Clear, right? So you don't want to do it directly. But AMPA receptors are ligand ion channels, and they contain modulatory sites, and they're AMPA receptor potentiators that are available, very potent, very specific. And here, this is from David Lodge when he was at Lilly. You can activate AMPA receptors with these compounds. This is a Lilly compound. These two are Lilly compounds. You can actually stimulate the hell out of AMPA receptors in terms of the firing rate, like physiologically, and not activate NMDA receptors, not get rid of that magnesium. So, and we know that these compounds are safe they've been in the clinic. Now, there's some work from the laboratory of Lilly showing these compounds are very effective, very potent in the forced swim test, suspension test. They're terrific compounds. This is some work that Beata Legutko did, who came from the Institute of Pharmacology. She was a postdoc at Lilly, showing that, in fact, in primary cell culture, as you would expect, when you activate AMPA receptors, here you put in AMPA itself, you get a huge increase in BDNF. Now, if you take these Lilly compounds and put in vitro, you get a big increase in BDNF. Now, the question is, how can you do that? Well, you have endogenous AMPA in the cell, endogenous glutamate in the cell culture. If you have a little bit of glutamate, a lot of this AMPA receptor, you get a nice effect. You can block this with NVQX. You cannot block it with an NMDA receptor antagonist. So it's purely AMPA receptor modulation. And here's some work that Arzina Matchkowiak did at Lilly. She's also at the Institute, showing that that was in vitro, right? Cell culture. Here, you can get something, excuse me, in vivo. 6 hours after a microgram per kilogram, you start seeing changes in BDNF, which are sustained. Very interesting. So I think AMPA receptor potentiators are a way that you could develop rapid-acting antidepressants, perhaps without the dissociative effects, because you get around NMDA receptor blockade. And as I said, we put a couple of those compounds in the clinic. They were stopped for toxicology reasons, but they were stopped for toxicology reasons. They were giving rats these AMPA receptor potentiators every day for months, and they saw some excitotoxic damage. If these compounds work through BDNF to have an rapid antidepressant effect, you don't have to give them every day. You give them once a week. And if you went back and did those toxicology studies, I guarantee you they wouldn't produce an excitotoxic lesion. So if I had another 10 years to work, another $10 or $20 million, I would start a company and resurrect this project. I think it's a really terrific idea. So I'd like to show you, so Barbara showed you Gabriel Novak and Piotr Popek. This is a much different photograph. And here's Beata Legutko, Arzina Matchkowiak, myself with a bigger mustache. And one other thing I wanted to say in closing, and I still have about 5 minutes for questions. So we consider this an important achievement. There was a biotech conference here a couple of weeks ago, and the CEO of Ryview, which is a large pharma, put up this slide. This is a cartoon of the NMDA receptor. It's the famous biomedical scientists and their discoveries. So that's it. So I'll end my lecture. Thank you for your time, and sorry if I ran too long.
Any questions? Please, Professor G.D.Sc.
Thank you very much for your lecture. Fantastic. I like to hear. I was happy you mentioned BDNF because actually we've known, we considered BDNF for so many years, but there is also this nice hypothesis of Finnish group and there are some tracks.
I know it. Irocastrin, of course. Yeah.
What do you think about it?
I like it. And so let me tell you an interesting story. So when we talked about this, the papers were published, I think 20 years ago, more than 20 years ago. And so we said on the AMPA potentiators, the antidepressants, this is old stuff. And so the first review we got back and said, I don't want to say the word in English, it's movno, because you can't form BDNF that quickly. And the guy didn't know what he was talking about. because you can't form BDNF that quickly. And people did infusions of BDNF into the central nervous system, and guess what? You produce an antidepressant effect.
But no VTA.
Could you?
Infusion to VTA.
No, I think they infused it, actually, I think they put it in the lateral ventricle. I don't remember, but I think that was Ron Duman, if I'm not mistaken. And infusions of BDNF, I can dig out the paper, it's an old one, will cause an antidepressant effect.
No, I only mentioned this because the story concerning BDNF is complicated. It works differently in different
Absolutely.
Parts of the brain. So
Absolutely.
that's why I thought that this Castron paper is very interesting.
Absolutely. I agree.
But he showed this with fluoxetine
Right.
or imipramine or others.
Yes, but it takes weeks. It takes weeks. That's the issue, is that eventually you get changes in BDNF production, but it takes weeks and they're very modest. So, maybe more is better. Please.
I have it, yes. So maybe I should comment because I'm the co-author of this Cell paper, Nature Neuroscience paper, concerning the fluoxetine and ketamine and track B. So I think there is largely a misconception about BDNF. BDNF is stored in the intracellular secretory vesicles, and there is abundant BDNF in most of the synaptic endings, but it has to be secreted to work. So actually it's a question about the secretion, and this is an activity-dependent process. So the second very important notion is that it's not BDNF which is rate limiting, but it's surface located track B. So what are these antidepressants doing? And I think the genetic evidence is solid, because when we mutate the binding sites on track B, transmembrane domain, nothing happens. So what these antidepressants are doing, they stimulate the exocytosis of track B to the cell surface. Also, track B in the adult brain is largely sitting in the ER and Golgi, and you need to take it to the cell surface. And that's the mechanism of action. So to that end, what you talked, MK801 is known since 30 years as a robust inducer of both track B and BDNF.
Absolutely. And so, I failed to say that, thank you so much. I failed to say that in the lecture, but I want to repeat it, think about it again, is that NMDA antagonists are neuroprotective, right? And they also have some neurogenic properties because of the effect on BDNF and track B. So it's been known, and if you think about chronic mild stress, you're stressing these animals, you can destroy or you can damage the hippocampal cells, and part of the antidepressant effects may be neuroprotective, for sure. So it's a great comment.
Any other comment, question?
I'm here, I'm not going anywhere for a couple of days, so there you go.
Okay. I understand that you are trying to point out that ketamine is not going, because of several reasons. First of all, because of its dissociative effects, psychotropic, generally speaking, effects, is not going to be a serious drug, antidepressant drug. Okay? And that's why companies, Big Pharma, is very interested in finding some new ketamine-like compounds, okay, which would be devoid of the psychotropic effects. But there are some other people who believe that ketamine, like other compounds like psilocybin or others, that those psychotropic effects are required for these compounds to express the antidepressant activity. What do you think about the possibility that the drugs which act like ketamine are devoid of dissociative effect, would they be antidepressants or not? Are those dissociative
I
effects
understand.
require?
I understand what you're saying. So for me, the target engagement theory is still it's still in dispute. For me, that's logical. It's Occam's razor, and that you need target engagement, and that the dissociative property is part and parcel of blocking that NMDA receptor, because you see it with compounds that block activity of the NMDA receptor generally have dissociative properties. We saw it clinically with Trexopradil. MK1 was in clinical trials. Some of the competitive antagonists, you see it. And so, so let me go back to the 5-HT.
So ACTC doesn't have psychotropic effect.
Right, but that has not been shown to be, effective clinically, and we don't know.
Oh,
Right.
as far as I know, it was effective, but.
It's
it has
effective.
some
It's effective
other
in animal
side effects,
models,
yeah.
but you see, it's effective in animal models. But you see, with memantine, for example, it's very difficult to show an I showed one paper from literature. It's been very difficult to show an antidepressant effect of memantine, and I think it's because they're not giving enough to engage the NMDA receptor. So if you say it's psychotropic or not, let me just say one other thing in conclusion. We can talk about 5-HT2A agonists, because that's what Professor Papp raised the point about. These compounds are also antidepressant, and they're supposed to be, and they cause psychotropic effect. They're hallucinogens. And so is that part of the experience? So the answer is that may be also an issue of target engagement. However, there's a company called Intracellular Therapeutics who has developed a biased 5-HT2A agonist. Doesn't cause head twitches in animals, which may be an issue related to target engagement. Now, if they put that in the clinic and they get an antidepressant effect, then I will say that the psychotropic effect is not part and parcel of it. So I think that's going to be a definitive study. But in terms of other compounds, and I showed that point before, things like linesamine, where they got some very transient effects, they also didn't get any dissociative effects that they could measure. And I think that's why, you can argue both ways, but just from a biophysical standpoint, for me, it's the target engagement that's important. There's one other thing I want to say about the 5-HT2A agonists. They're also very potent plastogens. They're neuroplastogens. They cause BDNF, elevation of BDNF levels. I don't know about track B, but they have some of the same characteristics as NMDA antagonists. And that may be, common molecular signatures of that's what you may need. I'm here today and tomorrow if you can always ask me questions.